We say exercise is medicine, but I always say exercise is not the ultimate cure for everything. You still have to live healthy.
Welcome to Healthcare Perspectives, a podcast by Siemens Healthineers about medical breakthroughs with the power to improve lives everywhere.
In the greater whole of society, there's an ever-growing boom of people who are exercise enthusiasts, as we call them. And so it's really important to understand all of the health benefits that come with exercise, but within the group, these individuals aren't immune from cardiac disease. They're not immune from cardiac risk.
You've just heard Dr. Jonathan Kim, Associate Professor and Founding Director at Emory University Sports Cardiology and Team Cardiologist for Georgia Tech and the Atlanta Falcons, Hawks, and Braves. Here, he explains why exercise isn't the only factor in predicting good cardiovascular health. In this episode, Myra Cocker, Assistant Professor of Cardiology at Houston Methodist Hospital and Global Director of Clinical Science for Cardiovascular Ultrasound at Siemens Healthineers, is joined by Dr. Kim, as well as Dr. Dominique Hansen, Professor of Rehabilitation and Exercise Physiology in Cardiometabolic Diseases at Universiteit Hasselt in Belgium, and Secretary of the European Association of Preventive Cardiology, and retired professional soccer player and cardiology patient Daniel Engelbrecht.
Hello, I'm Myra Cocker. Regular exercise is one of the most effective methods to keep the heart healthy and efficient. In rare cases, however, there are reports of athletes collapsing mid-game due to cardiac arrest. Two prominent examples are professional soccer player Daniel Engelbrecht and college basketball star Bronny James, both of whom experienced cardiac events during their respective sporting activities. Though exercise is generally a key part of the rehabilitation process for those who've experienced cardiac events, caution should still be taken. This is where physician input is important and where testing and regular monitoring can be implemented to reduce the risk of further events. In this episode, experts in the field of sports cardiology and exercise physiology draw attention to the topic of cardiac health and particularly how it pertains to sports medicine.
Exercise is something that everybody should partake in. And when we think about the American Heart Association and physical activity guidelines, they recommend 150 minutes of moderate level exercise per week or 75 minutes of more vigorous exercise.
That was Dr. Jonathan Kim, Founding Director at Emory University Sports Cardiology and Team Cardiologist for several of Atlanta's professional sports teams, espousing the importance of physical activity for cardiovascular health. As the popularity of endurance exercise has increased over the past several decades, more research has been done in response.
There's a boom of individuals who love to exercise, really intensive exercise habits. Individuals who are addicted to ultra endurance type exercise. And so you have this whole population of young athletes who are playing sanctioned type sports and they require excellent care, and there's research topics and interest to ensure their safety.
These elite athletes may need to be more conscious of the health effects of their activities than a more casual athlete.
Understanding how the masters athlete interacts with exercise and potentially may lead to downstream risk factors or potentially even related to the development of some forms of cardiac disease is a really important interest, because we want to ensure people are exercising as much as they can. And at the same time, we want to ensure that people who exercise this much are engaging in it safely.
And those risk factors vary quite significantly by age range.
For the younger competitive athlete, these are generally genetically inherited conditions that can sometimes increase the risk of something happening during competitive sport or really at any time of day. So these are genetic structural cardiomyopathies, as we call them as a general bin. An example would be a diagnosis called hypertrophic cardiomyopathy. A lot of people have heard of that diagnosis where the heart can become pathologically too thick. There's other forms of genetic cardiomyopathy conditions as well. There are arrhythmia syndrome, so heart rhythm problems. Genetic arrhythmias, these are inherited heart rhythm problems. An example would be long QT syndrome. A lot of people have heard of that as well. And then there's acquired issues. So if you get a bad cold or an upper respiratory tract infection, sometimes that inflammation can lead to the heart. So this is something called myocarditis.
In young adults, nearly 20% of sudden death cases are linked to myocarditis, which can be caused by infectious diseases and go unnoticed. For retired German professional soccer player Daniel Engelbrecht, his career-ending heart condition has been linked to an illness he experienced 6 months before his initial cardiac event.
I was never the type that stay at home when I was ill. As long as I can stand on my feet, I went to training. In the January before, I remember I was ill, so I'm laying down with fever, laying in my bed. But at this time, we had a new coach, and I wanted to show him for sure that I am able to play in the games we have to play. I didn't want to take a break. So I would say that was the biggest mistake in my life, because I'm not staying at home with fever. I take some medicine and say, oh, no problem. I will go to training and I am able to play. I think that was the mistake I made for the heart muscle inflammation, because 6 months later, I had that problem with the heart.
But for pre-existing genetic factors, diagnosis isn't always so straightforward.
For the genetic conditions, sometimes these can be hard to detect. It can be scary to hear, but not all the time will symptoms be a marker of one of these conditions. And it is true that sometimes a sudden cardiac arrest can be the first manifestation of some of these disease processes. So that's why it's critically important whenever we are evaluating younger athletes prior to sport participation in the screening process, not just to go through symptoms, but family histories as well. For young athletes, we have something called the 14-point American Heart Association History and Physical. It's not just a family history of high blood pressure per se. We're really focused on, do you have a family history of somebody who had an unexplained death when they were young, before the age of 50? And then we go through the series of these genetic conditions.
Depending on the patient's answers to the questions asked, their doctor may then elect to do a cardiac-focused physical exam.
A physical exam is very focused, looking for heart murmurs or other specific findings that could be consistent with some of these different conditions.
For older patients, risk factors might look a little more straightforward than their younger counterparts. At Universiteit Hasselt in Belgium, Professor of Rehabilitation and Exercise Physiology, Dr. Dominique Hansen, knows that a patient's previous cardiac history plays a major role when reviewing their risk.
Every patient is very different. So you have patients with lots of comorbidities and positive risk factors, while other patients barely have any comorbidities. And practically speaking, for example, if you have suffered from a heart attack, and whether you have diabetes, yes or no, hypertension, yes or no, or overweight, yes or no, that would completely change your exercise that you need in daily living.
The recommended exercise regime may be highly individual. Still, for Jonathan Kim, it's not generally necessary for people to gain clearance for exercise from a healthcare professional unless they plan to embark on an extreme regime.
Everybody, as they get older, should be seeing a doctor for your physical, and they should be looking at your blood pressure and asking you what your symptoms are. And you get standard of regular testing in the primary care physician's office to kind of pick up potential clues as to, hey, maybe this person should be further investigated, whether or not this person wants to train for a marathon or not. So I don't want people to take the advice that anytime you want to do one of these things or all of a sudden become more intensive, you have to get quote unquote clearance or some sort of testing or an evaluation. That may not be necessary, but it really is necessary that everybody make sure they have the regular routine medical care.
After I collapsed on the pitch, no one suspected that there is something wrong with my heart. So I resumed the game. I continued to play for just 10 minutes or 15 minutes after I collapsed, because everyone thought it was a heat stroke, but obviously it wasn't a heat stroke. And after 10 minutes, my coach changed me because he said, Daniel, something is wrong with you because you're running lines. It's not normal. I took a break for 10 days and started playing football again. So that was the first time I felt that there was something wrong with me, because I felt that I simply couldn't give my 100%. I told myself it was probably because of the week I had taken the break. So I didn't worry about as much. And 3 weeks later, at the 10th of August, I played the first game after my collapsing. I felt that something was wrong, but I kept pushing myself, but it was not possible. At one point, I felt that I would collapse after the next sprint. So I signaled to my coach that he should substitute me, because if I would do one sprint more, I would collapse again. Immediately, the physiotherapists and the doctors came through the pitch running to me and asked, "Hey, Daniel, what's wrong?" And then I say, "I couldn't move, so I couldn't breathe. I'm feeling a little bit dizzy, so something is wrong. My knees are shaking. I couldn't hear, I couldn't see. So it's the same symptoms like the last time." And they said, "Okay, give me your hand." They took my hand, checking my pulse, and said, "Crazy. Your life is in danger. Your pulse is down to 20.
When former professional soccer player Daniel Engelbrecht was just 22 years old, he collapsed on the pitch in an event that would completely change his life. After being rushed to the hospital and into an MRI for testing, doctors discovered a dangerous inflammation of his heart muscle. They also diagnosed a heart rhythm disorder. According to Jonathan Kim, the symptoms that Daniel experienced were all classic signs of a cardiac event.
The critical point of emphasis are exertional symptoms. Chest pain or chest tightness, feeling like there's a pressure, somebody pushing on your chest during exercise, and the only thing that makes it stop is you have to rest and it goes away. That is a concerning sign. Shortness of breath that's out of proportion to what you're doing. If you're doing high intensity interval training, you're obviously going to be extremely winded when you're doing the exercise. So we're talking about noticeable differences where all of a sudden you're way more short of breath at an activity where you shouldn't be short of breath. If you faint in the middle of exercise, particularly when you didn't feel it coming on, that may be the most red flag symptom of them all. So if an athlete comes to see me and they tell me, "I was in the middle of running down the court in the middle of a pickup basketball game. Next thing I know, I'm on the ground and people are looking at me." We call that unheralded syncope. Syncope is the medical term for fainting. If I have an athlete who sees me with that complaint, I tell them, "You can't do anything until we figure this out."
One proposed solution to prevent sudden cardiac events like Daniel's involves the implementation of regular required ECG screenings, though Jonathan Kim believes that this isn't necessarily the best approach.
The challenge is that we don't have the truly robust data to clearly show that ECG screening actually saves lives and improves outcomes. When you add the ECG, you can detect more things that a history and physical will clearly miss because of what's on the ECG. But that hasn't translated in the studies to show that it's saving lives.
A big challenge, he says, is having these test results read by practitioners who aren't familiar with the somewhat unique physiology of elite athletes. The so-called athlete's heart syndrome, a lay term that describes normal adaptive response to intense training, is a perfect example of this.
Athlete's heart is a normal adaptive response to exercise training. So it's how the heart adapts to the hemodynamic stresses that occur, whether you're an endurance athlete or a strength athlete. Those are different hemodynamic challenges. The word syndrome, I would advise anybody listening to this to not use, because that suggests that it's quote unquote bad. It is not. Exercise-induced cardiac remodeling is the medical term. There are no symptoms of an athlete's heart. That's just a benign condition. And ultimately, if it's a non-sports cardiologist, sometimes they can be confused and think that, oh, this looks like a pathologically enlarged heart. Well, a sports cardiologist would know better and say they look at that and no, this is an athlete's heart. So there's no such thing as quote unquote symptoms of an athlete's heart.
Though there is a place for ECG screenings, the most important factor to consider is whether it's being implemented with care. For Jonathan Kim, this involves the consideration of an athlete's access to further medical care in the event that a screening uncovers something potentially dangerous.
ECG screening has a role if you've got the right expertise and whoever is designing the program has thought very critically and importantly about the downstream. Because if we get a bunch of people who don't know how to read an athlete's ECG and they're now recommending all this testing for people who don't need it, or even if they're appropriate tests, but those athletes have a hard time getting the test, you can imagine that it can be a big problem. The infrastructure of the country is just not designed to handle that. You don't want to harm people by doing this and marginalize any sort of group of people that may already have challenges because they live in an underserved neighborhood.
On January 2nd, 2023, professional football safety Damar Hamlin of the Buffalo Bills collapsed in the field after making a tackle in a game against the Cincinnati Bengals. Hamlin was quickly attended to with an AED, or automated external defibrillator, by medical staff before being rushed to an ambulance to a nearby hospital. After a lengthy recovery period, Hamlin is once again playing in the NFL and has become an integral voice in raising awareness for the need of AEDs in public spaces, especially in schools. For Jonathan Kim, Hamlin's foundation and his outspoken advocacy for this type of first response has made a huge impact in the US.
Over the last year, all of a sudden we have such interest from a legislative standpoint. There are bills that are being passed through state legislatures. There's a federal bill called the Access to AEDs Act that was introduced to Congress that is obviously still working through that process. A lot of this is because of all of the passion that DeMar's put. The National Football League formed something called the Smart Heart Sports Coalition as a response to DeMar's event, which has the support of really every healthcare organization like the American Heart, American College of Cardiology, Red Cross, you name it. And this is pushing states to pass laws that all high schools should have access to an AED. All high schools should have an emergency action plan. Before all this, believe it or not, only 7 out of the 50 states had those laws present. It's almost shocking.
This sort of legislation is especially critical for schools lacking the budget and resources to provide these services on their own.
Who gets hurt the most with the lack of AEDs? Is it the private high school in an affluent neighborhood? Of course not. It's the high schools, the schools, elementary schools that are in underserved neighborhoods that don't have the ability to have these. There's no reason why every child in this country shouldn't be in a situation where if something catastrophic occurs, and we know these cases occur every day, that there isn't a plan in place, an AED nearby, and people who know CPR, because with that, survival can go from a dismal less than 10% for an out-of-hospital sudden cardiac arrest, all the way up to 70%.
And Daniel Engelbrecht stands today as a testament to the incredible life-preserving power of these devices. In fact, the major key to his recovery was also a defibrillator, one that was surgically implanted in his chest.
The defibrillator lies under my breast and it monitors my heart. So if my life is in danger, it sends a shock and restores. So he resetted me that I have a normal heart rhythm again. So it can save my life, but it still doesn't solve the underlying problem. He just monitors my heart. And if I'm in danger, he is my guardian angel.
Sports also plays a great role in the prevention of a cardiac event, especially in patients with cardiovascular disease. For rehabilitation and exercise experts like Dominique Hansen, the implementation of an exercise program can be essential when treating a patient who has experienced or is at risk for a cardiac event.
We know that exercise training or physical activity is one of the cornerstones in secondary prevention of cardiovascular disease. And what we have discovered is that when it comes down to exercise and physical activity, precision really matters to prolong longevity, to reduce the hospitalizations and the risk for major adverse cardiovascular events. So when I talk about precision of exercise, well, if you talk about pharmacology, precision really matters. Dose, timing, up titration, exercise is the same. So it really depends on the volume, the intensity and type of exercise. What are the health benefits that you can achieve?
But before any medical recommendations can be made, a full cardiac assessment must be conducted.
The first thing that a cardiologist very often will do is, of course, have a blood sample analysis for your glucose, your lipids. Also, he or she will execute a blood pressure assessment and a waist circumference assessment. Then a resting EKG analysis is very often done. And after the resting EKG analysis, then an exercise test combined with EKG monitoring is executed until maximal effort. And actually, the maximal exercise test is really key to understand whether exercise is safe for you, yes or no.
Another important assessment is to reevaluate lifestyle risk factors. Straightforward fixes like smoking cessation and a more heart-healthy diet can make all the difference.
Cardiovascular disease is very often the result of a different combination of lifestyle factors. That is also the reason why I should target those different factors. For example, healthy nutrition. When we talk about healthy nutrition, we very often try to propose the Mediterranean diet, for example. Of course, quit smoking is a very important key aspect in secondary cardiovascular prevention. And also trying to cope or reduce psychosocial stress, because we know that lots of psychological stress really can increase the risk for cardiovascular events as well.
Together, physical activity, smoking cessation, psychological support, and healthy nutrition make up what Dominique Hansen refers to as the 4 pillars of cardiac rehabilitation. And that rehabilitation is critical in allowing patients to return to their daily lives.
I think the best parameter to target in patients with cardiovascular disease is being able to live the life you want. So basically, the ability to participate in whatever you want to participate. Is it in your job? Is it into sports or whatever? That seems to be the best parameter you should target in cardiovascular rehabilitation.
When all is said and done, though perhaps the most crucial element to successful rehabilitation story lies with the patient themselves.
Adherence. That's the Achilles heel in secondary prevention, adherence of the patient. So what a clinician or a physician really needs to try to do is to find the intrinsic motivator to change your lifestyle. That's, I think, the key aspect. And of course, it takes time to do so, but evidence clearly shows that if people really find their own intrinsic motivator of why the lifestyle should be changed, then they're off to a better health for the rest of their life.
It is important to note, however, that exercise recommended by cardiologists for rehabilitation purposes wouldn't necessarily be equal to a patient's previous activity, at least not immediately. Dominique Hansen's recommendations after infections reflect a patient like Daniel Engelbrecht's experience.
Don't start too high and too long after infection, and really have your checkup at the cardiologist's office. That's really of key importance. If you want to return to sports on the level you're used to do sports, do it gradually, build it up, and listen to the symptoms of your body. If you feel palpitations, dyspnea, chest pain, shortness of breath, those are yellow flags that really should alert you that something is going on.
And for patients who have suffered from major cardiac events, the timeline for their return to sports may not be cut and dry.
I was 26 years old when I have to stop it. Wasn't the best age for a football player, and I want to climb on the top of the world, but I have to be honest to myself that after the heart muscle inflammation, I came never back to 100%. I just played with 60, 17%. I was a player who lived from his power, and I didn't have the power again like before.
For him, the lesson learned from his illness and rehabilitation has been a very personal one.
You have to let your body recover. If you wouldn't rest and if you wouldn't give your body a break, you have to pay the price that I paid for my mistake, and I have to pay it until the end of my life.
At Universiteit Hasselt in Belgium, one of the key tools used by Dominique Hansen for cardiac rehabilitation is a very familiar object for many of us.
For exercise training and physical activity, you have lots of physical activity trackers. There's lots of technology available where you can look up how can I have a good approximation or determination of the intensity of the physical activity and exercise.
Though these off-the-rack trackers are a new phenomenon, cardiologists have been employing daily monitoring for over a decade when it comes to patients with cardiovascular disease or heart failure.
More than 10-15 years ago, telemonitoring was really introduced in the care of cardiovascular disease. What we notice is that in patients with heart failure, if you do a daily assessment of simply the blood pressure, heart rate, and body weight, then you can predict hospitalization weeks before the hospitalization actually occurs. So that gives you the opportunity to intervene, to call the patient, ask what's going on, are you taking your medication, or maybe the medication is not working good enough anymore, and then you can intervene.
For Dr. Jonathan Kim in Atlanta, his experience with retail activity trackers has been cautiously optimistic.
Sometimes it can be helpful. I have certainly had patients who have a known diagnosis of, let's say, atrial fibrillation, and they have an Apple Watch. I didn't tell them to buy it. They already had it. I may say, hey, you know what? If you feel symptoms, go ahead and get an EKG off your Apple Watch, get that PDF and send it to me. And so there can be strategic ways to utilize them. I just think a lot of caution is advised right now just because we need to learn more.
It's been estimated that around 1 in 40,000 to 200,000 athletes experience cardiac arrest every year, and according to the World Health Organization, almost 18 million people die from cardiovascular disease annually. Though perhaps more uncommon, even elite athletes are not immune to cardiac events. With a combination of preventative screenings, awareness of both causes and symptoms, and making technology like AEDs readily accessible to the public, healthcare professionals are making strides to reduce these numbers. As someone who's experienced this type of life-altering event, Daniel Engelbrecht knows better than anyone to never take good health for granted again. Here is his advice to all athletes and sports enthusiasts.
I would advise them not to start until they feel completely better, because that is a mistake a lot of players do, because they want immediately back to the pitch and they didn't want to take a break, but it's not good, and the price you have to pay is much higher than if you are laying just for 1 week more or 2 weeks more in your bed. So listen to your body, because you just have these only one health.
You have been listening to Healthcare Perspectives, a podcast by Siemens Healthineers. We pioneer breakthroughs in healthcare for everyone, everywhere, sustainably. Subscribe to us and always get the latest episode in your podcast feed. Or visit siemens-healthineers.com/podcast for more. The opinions expressed by the guests and contributors in this podcast are their own and do not necessarily reflect the views of Siemens Healthineers. The statements by Siemens Healthineers customers in this podcast are based on results that were achieved in the customer's unique setting. Because there is no typical hospital or laboratory and many variables exist, for example, hospital size, samples mix, case mix, level of IT, and/or automation adoption, there can be no guarantee that customers will achieve the same results. This podcast describes possible future ideas and concepts. It is not intended to describe specific performance and/or safety characteristics of currently planned or future products. Future realization and availability cannot be guaranteed.